Okay, great. We've got 7 o'clock in the UK here, so I think we will start. Thank you very much for everyone that's joining live and for all of those that are watching back as well at a later date to be confirmed. So thank you very much for joining us. My name is Richard Artingstall. I'm Director of Teleconsulting, and I'd just like to take a couple of minutes just to talk about VetsCT before we introduce Dominique and the talk tonight. Really, just to talk about all of the clinicians that we work with here at VetsCT, Dominique being one of them, and what we provide across the board. So VetsCT, as you know, I'm sure you've signed up to this, so you're very familiar with VetsCT, hopefully, and if you're not, then you do scan that QR code and have a look through our website. But we're a global team of over 200 specialists, and essentially what it boils down to is we're here to help you, really. VetsCT provides exceptional radiology and advanced imaging services. We also have an arm which is specialist advice, and that's what I'm just going to talk about for a couple of minutes now. And then we also have an arm of education services as well, where we provide residency and student training for universities and specialty centres throughout the world. So I'd just like to talk very briefly about the specialist advice service that we've got. And this is a subsection of VetsCT. We've got probably 11 different disciplines, 50 different specialists within that. And we provide written specialist case advice to you in your clinical setting, wherever that might be, in primary practice, general practice, specialty centre, wherever you may be, university centre. Written specialist case advice within 12 to 24 hours. So this case advice, it enables you to treat and manage cases in-house, whether that's keeping them in-house or deciding on that secondary pathway and helping you with decisions. Essentially, we're like a specialist team sitting on your shoulder, which you can rely on. We give really fast turnaround times, within 12 to 24 hours, often sooner in some cases. And one of the unique things with VetCT specialist advice is we give unlimited follow-up. So we consider managing a case a bit like a conversation where it's not just a one-stop transactional shop where you can answer everything. Things evolve, conversations evolve, and cases evolve. And so once you create a case, you can have that conversation with our specialists through that as well. We provide PDFs and notes from our platform as well. So you can share those with colleagues in-house. You can share them on internal messaging groups, WhatsApp groups, text groups, whatever you use. And you can have very detailed notes to add to your file as well, so you can keep track of those. What we do know is that clients are absolutely delighted to stay with that vet that they have contact with, the vet that they know and trust, partly because the advice that we can give really clear, detailed next steps and reduce that uncertainty. So it's that sort of relationship that we can provide, not just with the vet, but also the owner as well, and that bond. We're really, really easy to use. You can use us on the desktop, click on the QR code, find us through the website, or download the VetsCT app as well, and you can access our services through that on your phone or tablet. And to use us financially and to pay, you don't need a subscription necessarily. We offer subscriptions which provide really good value, practice-wide support. And you can just get a pay-as-you-go, case-by-case advice as well. So if you want anything more, then please do have a look at that QR code. That'd be great. Dominique, if you don't mind moving the slide, that'd be great. So if you do want any more information, then please email me directly and get in contact there. That would be fantastic. And we can always arrange a demonstration run through. Next slide, if we can. So just a bit of housekeeping today. This is obviously going to be recorded. So if you've signed up and you're watching, you will get a full recording at the end that will come through to your email. And we will be taking questions at the end, but not live questions. So there's a Q&A box at the bottom of the Zoom screen here. If you want to put your questions in throughout, then do put them in there, and we'll be going through those questions at the end. And the microphone is off, so there's no active questions. So that's me done. Thank you very much. I'm really, really looking forward to this talk, actually, because I'm a surgeon by trade, and And obviously, abdominal sort of evaluation is part of that. And it's always been something that I've been hesitant to do, I suppose. Not that I've got expertise in it at all, but it's really that sort of understanding and knowledge and getting guidance and the tips and tricks around GI ultrasound. So we're very pleased to have extremely well-renowned specialist Dominique Penninck today, which is VetsCT ultrasound lead, how to get the most from your GI ultrasound and tips and tricks. So I will leave it over to you, Dominique, but thank you very much for being with us tonight.
Thank you for your introduction, and let's jump into the topic. Trying to get the most of the GI evaluation can be quite challenging, as many of you know. Then I decided to start this by showing you this evaluation of Enzo, and at least part of it. And what you see most commonly when you put the probe on the abdomen is a lot of artifacts. And you may be lucky enough to recognize bowel segment. Then the important part is often to evaluate what you can, if you can see through the reverberation artifact, then recognize the bowel, recognize the layering, recognize the mesentery nearby. It's a lot of things to incorporate at once. We are going to also have to pay attention to the contents, and things can be quite really confusing. And you see here the probe moving back and forth in that cranial abdomen of the dog. We'll pause on that and we'll go back to Enzo at the end of the presentation. What I would like to do now is basically take you through what I suggest is actually a decent evaluation of the gastrointestinal in dogs and cats. Many of what I show are going to be on dogs, but whenever appropriate, I will actually make mention of cats. Then GI is actually a very large part of what we find in the abdomen. And as such, if the animal is presented for GI disorder, it's quite indicated to try as much as possible to have an animal fasted. 6 to 12 hours, it will be what I would recommend. And again, I wouldn't refuse to do an ultrasound if it's not fasted, but many things may look different because it's actually in digestion phase. Then very important to keep that in mind is an ultrasound has far much more value when it's placed in a defined clinical context. And knowing, for example, if the animal was fed, when was that? Was it a half hour ago? Was it 7 hours ago? And then because it's such a large part of the abdomen, I think it's important to be systematic. I tend to do my ultrasound with the animal on dorsal recumbency. And doing so, I kind of will start by the most cranial portion of the GI, which will be the stomach, the larger part of the GI tract. And as the probe indicate, always important to do complementary view. When I'm speaking about section in the GI, if I say a transverse view of the stomach, which is this one, or a sagittal view of the stomach, I'm actually referring to the axis of the organ and not necessarily the axis of the body itself, okay? Which is important because, as you can imagine, the loops are changing so much into the abdomen in orientation, then I think it's important to define that in comparison to the lumen of the segment you are evaluating. All right, then stomach, hopefully we'll go through the details of that evaluation in a minute. And then from there on, in small to medium-sized dog and cats, usually not too difficult to find the paloduodenal junction. Then we come straight down, we'll find the duodenum, which is the most superficial loop that is actually having a straight course. And we'll take always complementary views. And also, if you notice, in these two examples, the stomach and the duodenum, I have a microconvex probe, and I'm going to try whenever it's possible to adjust the depth in a way that I can see what I want to emphasize, hopefully in the middle of the screen. And then also always useful to have other anatomical landmark included. For example, in this case, the right kidney that is dorsal to the duodenum. All right, and then here the same now in a view, in a sagittal view. Then when it comes to now the central portion of the GI and all the loops of jejunum, that's tricky because you cannot see all of them systematically, but what you will do your best to actually see most of them, and we'll detail through a video how to try to do that. And then also take representative images of these loops is very important. Then finally, go to the ileocephalic junction and different segment of colon, ascending, transverse, and descending. Again, we'll go through the details of each of them and representative images of this segment. Now I'm giving you example of images that are taken with a linear probe. Then, of course, you are dependent on the equipment you have available in your practice. But very important that if you do have access of both microconvex and linear, to use as much as possible the linear when it's allowed, because usually they are higher resolution probe and will give you a much nicer definition of the wound. All right, this is like painting the big picture of the GI. Then what we'll start doing now, we are going to start with the stomach. Then, as you know, the stomach is the larger portion in the cranial abdomen, and in a dog, actually, that stomach is positioned perpendicular to the axis of the spine. And you can see that on the radiographs on the right. And also the main compartment we are going to evaluate are going to be fundus, body, and antrum right before getting into the paleoduodenal junction to evaluate further down the duodenum. All right, then let's look at that on a video, and notice that at the bottom we have the dog on his back. The probe, the line represent really the landmark, meaning that we want that landmark to be pointing towards the head of the dog. And then we are going to now, you see the way the probe is positioned, it means I'm going to be transverse to the stomach, and more precisely, because I'm on the left, it will be the fundus. Then we proceed now with this, and you will see that in the video, I really, as much as possible, want to include anatomical landmarks, like in this case, the liver that we see on the picture. And then as we proceed, we are going to slide from the left to the right. We see part of the spleen during the video as well. And then, as you know, right behind the stomach, we have a piece of colon right there. And important part is that despite the gas in the lumen, we still recognize layer in the wound. And in the stomach, the mucosa and muscularis layer are almost at the same thickness. Then we don't see the dorsal wall because of the gas in the stomach, but we'll proceed anyway. Now I've turned into a sagittal view, and I am getting in the portion that is the paleoduodenal junction, the end of the antrum and the beginning of that junction. And we'll discuss further down the duodenum later. All right, then gastric contents can vary enormously, can be just gas, especially if the stomach is collapsed like we see on the left. But the gas can be mixed with fluid and ingesta. In that case, it may be even a bit more confusing, because in this case, we don't actually see the far wall at all. And often, depending if the animal was fasted or not, we may see food material like this kibble. And if we do see that, it means that we have a stomach in action with food, and we see the contraction. Then the thickness of the wall of the stomach vary greatly depending on that. However, which is not acceptable, is to see that amount of fluid. Then this is what I will call the pointers, meaning that that stomach either has ingesta and is conquered with the clinical history, or it didn't eat for actually at least a half day, and now I encounter that largely fluid-filled stomach. Then no doubt, then it's very important at that point to go see the palaroduodenal junction. And in this case, we can see that there is obstructive foreign material associated with trunk shadowing. Then a fluid distended stomach shouldn't happen. And if it wasn't an obstructive foreign body, maybe there is actually a functional issue, but you will need to rule out that by looking carefully at the palaroduodenal junction. Then the preferred recorded view will be if I'm on sagittal, doing it at the fundus body and palaroduodenal junction area on that sagittal plane. And for the transverse one, the same, fundus, body, and antrum. Then being systematic is useful because we can fall back on it. Then the key point to remember for the stomach is that it can be quite variable in this degree of distension, depending on the amount of ingesta present in the lumen. And of course, that will affect somewhat the thickness of the wall that usually vary between 2 to 5 millimeter in a dog. And gastric wall layer are important to evaluate. They are usually close to each other, all right? Now, gastric contents, if we do not know about it by the clinical history, can be quite tricky to separate sometimes from foreign body, especially in a vomiting dog, or sometimes even from wall lesions. Okay, let's move a bit further now. And sorry, before that, let's go to the stomach in cats. Couple of comments. The stomach in cats tend to be more obliquely oriented than what I told you about being perpendicular in the dog doesn't apply in cats. Also, you see this region is actually fat in the stomach wall that you would also be able to observe more commonly in cats. All right, let's go to the intestinal tract. The intestinal tract is a good place to discuss the layering of the wall. And the first thing that you want to do really anyways, any place you are in the GI tract, is identify where is the lumen. Because once you have that lumen, then you know that on each side you have the mucosa, which is the thickest anechoic layer, and then come the bright hyperechoic submucosa, then again nearly anechoic muscular layer, and finally the serosa subserosa, which is pretty much just a bright interface. If we start with the descending duodenum, we already saw earlier, that's the only segment that come very, very lateral to that abdominal wall. And again, you would want to have cross-section and longitudinal view. Important to define that the lumen in this case is filled with a little bit of echogenic fluid. All right. Then, sorry, I pushed the wrong one. Then once you have defined this, and here we are at the duodenum, let's see that in action. And one thing I want to attract your attention to is making sure to find that palaroduodenal junction. Now you see it dive dorsally to come back ventrally. And then look, I barely touched that dog. Then very important, you have no pressure. And remember also that the duodenum is a very useful landmark, not only for the bowel itself, but because it's going to be near the pancreas. Then landmarks very key in illustrating your examination. Then duodenum in a dog, actually not uncommonly, you will see some little defect, hyperechoic defect, like you see here, and you will see some other one, like one coming up right there. And this defect, hyperechoic defect, represent Peyer patches. Important to recognize and not to confuse them with ulceration. Then also important to recognize that the duodenum at that location helps you to compare its thickness to the other bowel segment, like the jejunum segment and the colon, which you nearly see a very thin wall structure. And that's important because that's another way to identify the duodenum, especially in large dog, where the paloduodenal junction may not be that easy to find. And then in that case, we really know for sure that's duodenum. Not always that straightforward. Then again, can never say 100%. But in a cat, that's not the case. Then let's remember that. In the cat, duodenum and jejunum thickness are the same. And we switch to a linear probe without any pressure. Now we recognize the duodenal papilla. Then, and we also have landmarks of liver and kidney in the far field. Then if we do change the orientation, we can then see the common bile duct going into that region. And that's one way to measure also that portion of the distal common bile duct. Then there, the clinical history is going to be important. Now, when we come to the jejunum, as we mentioned before, it's in the central abdomen, it's really, could be any place. Then how can we explore it? Well, I would say that one way to probably approach it, and you will see that in that clip, is that I'm going to use, first find the stomach, the colon, because they are next to each other. Then I do a zigzag approach in the abdomen, going from left to right, right to left. Then that way I will have most of it seen. And you will also recognize the mesentery that should be pretty uniform through the abdomen. Then that's another very important thing. And you see the spleen is commonly coming in the superficial aspect, and that's okay. That's a nice acoustic window. Then it doesn't prevent you to see well the bowel underneath. Then when you get close to the mesenteric vessel, pay attention because these are actually the lymph nodes. Then very normal jejunal lymph nodes and good anatomical landmark. And it's come to the size. In dogs, we know that the size of the animal will somewhat impact on the size of the bowel. And as you notice in this case, depending on the size of the dog, actually always the duodenum stayed thicker than the jejunum or ileum. And again, in cats, that's not the case. The duodenum will be the same as the jejunum, but the ileum will be slightly thicker. Just in between parentheses, this is just a representation that actually the relative thickness of the wall layer is also important to pay attention or to illustrate. And in dogs and in cats, and they are somewhat variable depending on the bowel segment we are looking at. Also remember that it will be somewhat affected if the dog is in, or the cat is in digestion phase. Then one of the key parts is always first look at what's happening in the stomach. Is it collapse? Is it gas fill? Is it ingesta fill? Because it's going to determine some of our, or the value of some of our findings. Then now the last segment, we are going to see how to evaluate the ICJ in the colon. Then first of all, the ICJ stay pretty much always in the right cranial abdomen of a dog, okay? And what we are going to look for is the ileum coming into the ascending colon. You remember the course, ascending, transverse, descending colon going into the pelvis, all right? Then let's look at that in action. Then if you have radiographs, again, cecum in the right cranial abdomen, and then you see that on this contrast view, the ileum is aligned with the ascending colon. Then in action, here we are in that cranial portion. We have ascending colon, thin wall, And you'll notice that the mucosa and muscularis layer are about the same. We have a gas-filled structure, but now we see the ileum entering the ascending colon. That's a key picture to remember. And then the cecum, which is a blind structure. In dogs, majority of the cases, it will be gas-filled, especially if it's normal. Very thin wall, about the same thickness as the colon, which means less than 2 millimeter. I would say usually 1 to 1.5 millimeter. Recognize also that the course of that colon will vary depending on what is filled with and depending on the distension of other bowel segment. And in this case, you see, especially when his feces filled, that he can be quite wavy in appearance. Then one thing I will recommend is that when we do actually evaluation of the colon, I always start at the pelvic cavity because I know that's the only bowel segment that will or should enter the pelvis. Then it will be next to the bladder. In this case, the spleen was large and was above it. But you see now the hand is moving along the descending colon. We have now the transverse colon that is pushed a bit more dorsally by the small bowel. And then we are now following the transverse colon right there, aiming towards the right side. And soon that will lead us to the ascending colon. Then again, here's the colon, thin wall. And, and if we follow that segment, we, not all the time, but we should very regularly actually find that connection with the ileum, but it's not always possible in dogs. Then now we switch to a linear probe, and again, you will notice that with the linear probe, the definition of the wall of the colon, despite all the artifact shadowing mostly due to the feces, we can see the two black lines of the mucosa and the muscular layer. Then really a good idea that once you want to evaluate wall, you will switch to a linear probe for that. And notice almost no pressure on the animal. It's another enormous tip, is as little pressure is actually needed, even for GI tract, where people have the tendency to think that because there's so much gas, they need to push to make it go away. It doesn't go away by just manual pressure. All right, then let's take a peek at what the ICJ and colon look like in a cat, because it's different in the sense that the cecum is small and often collapse. Then this is what we'll look for, the ileum. You remember I told you the ileum is actually the thicker segment in a cat, unlike in dogs. And then here we are. We are going to start in this case, stomach, colon. On the left side, we are sliding towards midline, and the colon is still there. It tends to sometimes dive a little bit. Now it's coming back to the right side. And if I'm coming on the right side, oops, here we are. That's the ileocolic junction. Another thing to notice is the fat near that junction. And again, colon, and you see how the fat is actually a bit more discrete and can be slightly hyperechoic to the adjacent mesenteric one. Then in this case, we see a folded lymph node, an ileocolic lymph node. And then again, now we have that nice view of the wall of the colon and the ileum. If I'm at that level, it means the cecum is nearby. This is really tricky at times in cats to see the cecum because it tends to be collapsed and then more difficult to identify. But with patient, you may actually end up being able to see it. Then we keep scrutinizing that area with more attention, and I'm going to advance slowly the video to show you an example of it. Then again, the lymph node, And here is the cecum. Here is the cecum. Really tiny little blib on the side of that ileocolic junction. Then actually, we have also that the image actually is a good representation of that cecum. On another cat, we will have the similar view, ileum, lymph node, entering pretty soon into the lymph node actually should be less than 5 millimeter, which is the case in this cat. Then very discrete location that need to really be scrutinized carefully. All right. Then after that, what I would like to do is point to you a few features. We now have an idea of how to run through the GI, to the different portion of the GI. Then what I like to use is key feature, and one is surely the GI contents. Let's make sure we pay attention to that. And it can be either food material that will often appear as, discrete hypoechoic structure within echogenic fluid, or anechoic fluid. Then again, nicely see the paloduodenal junction. Could be echogenic fluid. Commonly, you will see gas and this reverberation artifact. If you are at the level of the colon, expect to see strong shadowing because of feces. Strong shadowing, though, can be dangerous because you will be seen also in foreign material. Then identifying in which segment you are is key, because in this case, we are actually in the stomach. Then there's no reason to have strong shadowing material unless the owner report that they gave something that has the potential to be shadowing and you have a non-vomiting animal. All right, then beside the contents, wall thickness is very important. Wall thickness and layering. Combining the features are important, and it means that illustrating them is paramount to having a good exam. Then the wall of the bowel is measured by going from the luminal surface to the serosal surface. And you will see that having a representation of several bowel segments is important. And as we, he advanced the wrong way. All right, then what I like you to see in this animal, we have not only measured the wall that was thicker, but you can see that the muscular layer is actually as thick, if not thicker, than the mucosa. Then that's already a sign of pathology. And this is happening in several bowel segments. Then as documentation, you want to make sure to have for sure several segments illustrated. And you can go to the other extreme, which is losing completely the layer, like at the bottom. That's the lumen. And in this case, we don't recognize layers at all. But there are different levels of changes in the bowel. Oh, sorry about that. It was definitely me pushing the wrong way. And in this case, you see that we have not only evidence of fluid in this abdomen, but we have in this case bowel segments that are fluid distended, have echogenic mucosa. In this case, they have striation that often is a sign, is a signature for dilation of the lacteals. You remember we had also, and probably best illustrated is to have videos. And you will see that in this case, having the video of representing where all these bowel segments are changed will be very helpful for your review or if you send it for an evaluation by somebody else. And at times you may have really, really tiny feature, like actually tiny hypoechoic line in the mucosa that are probably not having too much significance clinically, but still good to pick on that. Then these are examples of wall layering being completely lost. And the way sometime to recognize that that mass is actually GI is by the presence of gas. Then be very attentive to that. But not only the presence of gas, but also the presence of, in this case, lymph node nearby. And this was part of a comprehensive mass. Then if you really had problem identifying its GI origin and there's not much gas, try to make sure to follow that mass to the point that that may be a junction, like right there. Then we go from layer to non-layer wall. Then that will be useful. Not also forgetting that you need to illustrate if they are a lesion or several lesions. If they are local lymph node being enlarged or not, are they hypoechoic? Are the lesion at times actually invading the local mesentery that may be increased in echogenicity, like in this case? And potentially, there may be other organs involved as well, like the kidneys, for example, or the bladder, or the liver. Then very important, potentially starting from a GI changes, you may end up having to look at the entire abdomen, depending on your finding. But illustration by short clips can go a long way to help you out. Then using all these parameters, I'm going to go a bit further to a last element, which is evaluating location of your bowel. We know some of them, like stomach, duodenum, but then jejunum is everywhere. But the course, the smooth course of the bowel through the abdomen are important to evaluate and to follow, because if they are actually not normal, what that could be is a signature for disorders such as hernia, intussusception, volvulus. Hernia could be umbilical hernia, could be inguinal. Then location and landmarks will really help you out. Saying that, I would like to finish up by going back to Enzo. And if we go back to Enzo, what we notice is that you remember in the beginning, confusing, there's so much gas near the stomach, and then we end up with this fluid-filled, distended bowel, where we still have layers. And again, now we have all this confusing structure. And now we have this hyperechoic line with shadowing, but that looks like it's within the lumen of small bowel that still have layers. And if I follow that structure, it seems to be oddly displaced. I have bowel in between, and then I keep going, and I still have that linear structure, but all the bowel nearby are somewhat having a strange plicated appearance. And you see where I am on the abdomen of the dog. And in this case, the other bowel segment are kind of folding above it. Then in a case similar to that, what comes to mind? Well, we do have evidence of foreign material within small intestine because the wall is layered like the small intestine. And in this case, we have actually evidence of plication. Then this would indicate that Enzo actually have plication that most likely is representative of a linear foreign body. And why is it so important to have good documentation? Because you see the plication on each side of the string type foreign body may sometimes mimic other things that we see quite often in bowel, which are corrugation. But the big difference is that rather than having folds of normal bowel that are crossed by a string, you see that there the serosa surface is actually straight. And the folded, the corrugated appearance is inner the bowel, and that can be seen with pancreatitis, with peritonitis, with enteritis. It's really non-specific, where the plication is a signature of foreign body. Then hopefully I kind of give you a few tools for evaluating the GI tract. That's about as much I wanted to go over with you.
Thank you very much, Dominique. If anybody's got any questions, then please do pop them in the QA box at the bottom. Certainly some beautiful images there, and I think it's just illustrated the power of getting those really good images. And you mentioned the short video clips. Would you recommend for people to do that as a sort of routine and a collection to start, getting a methodical way of short video clips throughout their abdominal evaluations in a certain way, or?
Yeah, I do. And of course, it can be a bit more confusing when it comes to GI, but especially when you have pointers like fluid accumulation. You have an empty stomach. Okay, let's say we have an empty stomach, but then you have a bowel segment like the one we just saw that have fluid accumulation, and then some material in it, or the wall is thicker than what you expect it to be, then having a short clip, maybe something like even 10 seconds, 10 to 15-second clip over that region, and mostly also somewhat overlapping to what it becomes different, because we then can assess better. And also a detail, but having the appropriate depth, because at times people are so focused on it that we actually don't even see the far wall, or they are so far away from it that we have a lot of unnecessary information from other abdominal organ in the clip. But that's something to keep in mind. But yeah, I do find that short clips are very valuable to help out in figuring what's going on.
That's fantastic. We've got one question that's just popped up. I'll see if I can. Is it possible to explain once more about the anatomy of the layers in the junction?
Sure. Do you want me to go back to it?
Yeah, feel free. Yeah.
Yeah. Let me find a nice. Yeah, because this is really key of starting the whole exam. Because honestly, when we start ultrasound, some of the vessel, you could confuse them with bowel, because they will be having that same appearance as the mucosa, right? Then the first challenge is finding the lumen. Then what you want to do is just observe. Then it's another important trick is be really slow, okay? Especially if you are frustrated. Don't speed up, just go even slower. And then once you are there, hopefully you see a little bit of motility, maybe, maybe not, but you may see bubbles going by. And if you see bubbles, then you can try to trace back, but you know that that should be the lumen. Then once that lumen is defined and you don't push too hard, then symmetrically you should have mucosa close to the lumen, and that should be the thickest portion of the bowel in the small intestine. And then you will see that thin bright line, that's the submucosa. And then another thin black line, which is the muscular layer. And that's the one that often is affected with some level of inflammatory or neoplastic changes. But that's what I usually was, telling my student, you look for two black layers, basically. The mucosa, that should be thicker, and the muscular layer. Then the serosa, subserosa is really mostly an interface. Rarely do we have really strong diagnostic value, although it does happen. Like in granulomatous lymphangitis, you will see the changes at that level. But that's mostly an interface. But surely the two black layer is important. And remember, if they are the same size or about the same size, measure them, because if it's 4 millimeter, maybe you are at the level of the stomach if you are far enough in the cranial abdomen. And if they are thin, you could be in the colon if they are about the same size. But if you are anywhere else in the small bowel, then remember that overall appearance, mucosa being much thicker than muscular layer.
Okay, great. There's a question around, are there any sort of ultrasound signs that are suggestive of mesenteric torsion, or if you're suspicious of mesenteric torsion? Are there a few key signs that you should look out for?
Oh, that's a very pointed question.
Mhm.
Mesenteric torsion may be really tricky on ultrasound, and I will highly recommend that in dissimilar pathology, which are often quite acute clinically and quite, having a sick animal, I would strongly recommend to have radiographs as well. We didn't have chance to discuss the place of, how they complement each other, but that would be one case where I would definitely recommend to have radiograph to support anything that you may have seen on ultrasound. On ultrasound is tricky because it depends if the segment or part of the segment that is actually potentially twisted is gas or fluid filled. And because you may see thinning of the wall because of vascular compromise, but they will turn, depending on the timing, also in thickening of the wall with murky margin. Once the vascular compromise is established and there is actually edema of the wall, then that's one of the top challenge of just diagnosing them based on ultrasound. You could use color flow Doppler, but again, color flow Doppler on the GI is also a major challenge. Then may not be your best tool to start on, but complementation with the radiographs would be definitely key feature.
Okay, fantastic. Certainly there was a magnificent view of the major duodenal papilla that was so clear that made it look so easy. The question is just really more information, but I suppose in the context of this talk, it's maybe tips and tricks around or to get a view of the major duodenal papilla.
Um, A lot of it may depend a bit on the size. And I would say if you don't have experience looking at that, I will probably try to practice on a smaller animal, like small to medium size dog, because it may be a bit easier. Cats actually are not bad neither. And then, for your anatomy, kind of have an idea of where that papilla should be, in along the duodenum. It will be in the proximal duodenum. Okay. And it's actually a landmark important because if you have a lesion that is near the papilla, of course, the surgeon would want to know about that. Then knowing that it's pretty much just right after the first curve is helpful as far as identifying where am I going to look for. If I'm already too far down in the duodenum, I know I'm not going to find the papilla at that location. Then having an anatomical landmark of that, and hopefully not too much gas in the ascending colon because it's right next to it, okay? But once you are at that location, to me, the best way is going on transverse view of that very proximal part of the duodenum, because that is where on transverse view, I will see that little blip of the duodenal papilla itself. Once I have that, just like in the video, I will then turn my probe longitudinal or oblique to catch the common bladder coming out of it. But it's not uncommon that you would not see a normal one. Then again, I don't want anybody to feel like, oh my gosh, I really don't know how to do this. On normal animal, it's just like the pancreas, right? When it's normal, the important part is scrutinize that location that you know you are not missing a lesion, but they can be really difficult and challenging to identify.
Okay, yeah, great. Got a question around, I suppose, food, I think, in the stomach and the small intestines. So, how does digesting food modify the thickness of the stomach and the small intestines? And does it make it smaller? Does it make the thickness smaller? A bit like if the bladder distends, I think, is the question.
Yeah.
Therefore, do you still evaluate the thickness of the intestines if the animal's not fasting?
Good question. I think If the animal is in active digestion, then I see evidence that there is food in the stomach, and I will see peristaltic activity. Peristaltic activity, if you stay and look at it, is about 2 to 5 per minute. Then I will see peristaltic activity, and then in that case, you're right. I will probably measure it, but I will not necessarily be able to conclude anything because even the mucosa, the proportion, you remember, I show you briefly that slides of the different relative thickness of the layer themselves. Clearly, the mucosa is stretching during digestion phases, then it means it's going to be thinner, but it's not because the muscular layer is thicker. It's just because the mucosa has stretched. Then you need to know your limits as far as then evaluating the GI when you have a non-fasted animal. Yeah.
Yeah, that's great. Thank you. Another really important question here around assessing ulcers, on ultrasound. So you mentioned Peyer's patches are commonly mistaken for ulcers. And can you speak for any of the key features associated with ulcers in ultrasounds? And thank you.
Yeah, I wish I'd pull an example for that. But yeah, my main feature for that is that if you have duodenal ulcer, most commonly you will have a focal or segmental thickening of the wall, and then you have a crater, okay? But then it means that wall itself, most likely not at the crater level, but nearby, will be thicker and will probably have an altered layering, because with the inflammation, they will decrease the sharpness of the layer visualization. And if the crater is deep, like you saw the Peyer patches, there are quite significant, divot within the wall. But if it's a crater due to an ulceration, I can tell you that the mesentery adjacent to it is most likely going to be bright and hyperechoic. Then that would be my two go-to feature: thickening of the wall and the fact to have a focally, inflame and therefore hyperechoic mesentery. And yeah, that would be probably the two main features that I think of that I will use for distinguishing the two of them.
Yeah.
Interestingly enough, I think that seeing Peyer patches, we don't see them in all dogs. Then I have a sneaky suspicion that just like the lymph node being a little plump and reactive, that seeing really well Peyer patches may be an indication that there's inflammation or that there was recent inflammation at that location. But don't quote me on that because I don't have any proof for it.
No, you didn't say it. You didn't say it. The question I was thinking as well is GI motility, but there's a question here about any tips establishing if the peristalsis is normal in a sedated patient, as it naturally could be delayed.
Yeah, absolutely. And of course, I'm surely, I would refer to more competent people than me as far as type of sedation that can affect GI motility. But I would be careful about that. And again, if I don't have food in the stomach, I am hesitating to comment about GI motility in general. I'm very careful about that. But if I don't have any food in the stomach and I do see active peristaltic activity and fluid filled, I didn't say distended, fluid filled intestinal loop, that will lead me to think that we most likely have some degree of enteritis, because I have actually in that case enough evidence that there is an increase in peristaltic activity.
Great.
Make sense?
Yeah, absolutely. Okay. I might come back to that question just because I don't know whether whoever asked the question on uremic gastropathy maybe just wants to ask a bit more specifically about what do we want to know about that. But there's one here that I sometimes see a varying amount of thin hyperechoic lines within the muscularis layer of the stomach. Would you say that these could represent Peyer's patches, or might they be something else, such as another normal or abnormal structures? So these are sort of hyperechoic lines within the muscularis layer of the stomach.
Exactly. And no, I think they actually have been described in in a publication, and they are actually muscle striation. They are fibers, muscle fibers, and I think when the muscle may be thicker, either because there have been a nut flow issue or that they have to be working more, especially near the paloduodenal junction, you may see this striation, but it is part of the muscle anatomy, except it's accentuated because the muscle may be thicker at that location. But I would just keep it really at that level and not go any further. Um, do you want me to answer also the uremic gastropathy?
Yes,
Okay.
yeah, I think so. Yeah,
Then uremic gastropathy would be, of course, suspected in animals that we know are azotemic and chronically or severely. Then you would see at times when there is uremic gastropathy, a thickening of the gastric wall, maybe even more pronounced, more in the fundic body region. And then what you will see is a discrete, when it's there, you will see a discrete hyperechoic line that is like on the deep portion of the mucosa. And that per se seems to be a signature of uremic gastropathy, specifically seen in that. And I know that in general, people struggle quite a bit with the changes in layers, and I understand why it can be really rather confusing. But in this case, your clinical background will actually help you to say, okay, well, it makes sense with what we deal with, which I've not done, but that would be interesting to do, is follow a patient that do have that and have the azotemia being resolved and see how much that sign actually resolve as well. Maybe, there are people out there who have that experience that could be worth actually publishing on it.
yeah. Great. I think we've got time for a couple more, and there's actually two that are sort of semi-related around the stomach thickness, really. So, when do you consider the stomach walls thickened if you're in doubt and it's not very thick? And a sort of second one, which is sort of similar, is how do you know if a stomach's thick or not when it's collapsed down and I suppose it's sort of bunched together? So it's assessing the wall of a stomach thickness, really.
Welcome to the club. I don't know. When it's collapsed, I will use not only the thickness, and in general, I don't ever want to just use one feature, morphological feature. Then, as you notice, I mentioned layering and thickness. Then I will combine both. And if there's anything that intrigue me on the layering, then I will scrutinize if there is any segmental change compared to the entire organ. But in the stomach, it's tricky because it's slightly variable appearance from the antrum and the fundic region. But if it's collapsed, I usually don't waste my time taking measurements of the wall because it's really hard to tell. Then, but now if I have a segment that is especially obviously highlighted by either gas distension, it can happen that actually the gas wouldn't be a problem for you measuring the wall because it's ventral. The thickening is ventral, then that would be approachable. Or fluid filled, then I will measure it. And I will usually in dogs consider that up to 5 mm is probably okay. But more than that is comparing what it looks like. If I'm at the body region, is it the entire body region that seems to be uniformly thickened or not? Okay, then that's what helped me to go in one way or the other. But on a collapsed stomach, I don't think anybody feel comfortable measuring them.
That's great. Okay. Well, I think it's 8 o'clock here in the UK, and we've had some great questions, and I think we'll probably wrap it up here, if that's okay. But Dominique, thank you so much. It was a really good overview, very well thought through, and beautiful images, and a really nice logical approach to that. So I hope everyone got as much value out of the talk as I did, and thank you for your time, Dominique, and thank you for everyone joining us. I'm not too sure if there's a final slide or so, whether we can just flick through to the end.
Yeah, you're right. There was a final
I think there is.
slide.
It might just be a thank you slide, actually. Any questions? Ah, there we go. Ah, I knew there was. So we've got more webinars coming up. I did have a list in front of me, but I've lost it now. But varying on orthopedics and internal medicine, I think. So do click the QR code. Head to the website if you want to see all the webinars before as well. So we've got a series of about 15 webinars, and we've got plenty of radiology webinars there as well, sort of introducing our specialists, getting to know them, understanding who you're working with, both through teleradiology and our specialist case advice as well. And if you are interested in specialist case advice, please have a look at that and do give me an email. But thank you, Dominique, for your time. It's amazing
You're
tonight.
welcome. My pleasure.
Very much. Goodbye.
Bye-bye.